Welcome, everybody. Public Health Grand Rounds, and we're very fortunate to have Dr. Scott Lindquist, who's been, by trade, he's pediatric infectious disease, but he's been in public health for many years as health officer at Kitsap County, and now he's our state epidemiologist and wealth of knowledge. So, Scott?
Questions as we go through. We'll be pretty flexible. I'm a very pragmatic person, and I'm also, I don't mince words. I'll say things as they are. And public health. I'm really worried about public health. I'm concerned about the future of it. I think it is really taking a bashing during a pandemic, 2 pandemics now, and I think public trust is low. I think a lot of public health has been politicized, and I'm going to talk a bit about what I see as the future for public health, and that is evidence-based practice, just like infectious diseases, just like your practice is evidence-based. Problem is, evidence-based and politics don't mix well, okay? And so how we span that. So at the bottom here is the first time I've really talked about this, and it says Public Health Solutions International. This is a not-for-profit company I started because I'm afraid that public health is not going to survive in the way that I think it needs to survive. So I am going to shift gears into a private consulting company to do this. And we'll talk about this as we go through. So first and foremost is data. And I probably should have asked you this before we go, but I assume forward will make it go forward. No. That'll make it go forward. No? There we go. I have no relevant financial relationships with any companies or anything that we'll discuss here. I am pretty much a free agent. And, okay, so. Okay, here's the things we're going to talk about in 2022. I handpicked what I see as the illnesses of public health concern. COVID-19, obviously, monkeypox, high pathogenic avian influenza. There's been a very large TB outbreak in incarcerated individuals, homelessness and public health, and then behavioral health and public health. So next slide. So let's just do a quickie on COVID-19. Here are these trends. Now again, these slides are due 3 weeks before I come and give the talk, so that's always a concern. I'll fill you into what these numbers look like now. They are actually improving. We are seeing a decrease. This is what we call an epi curve. Epi curve. Epidemiology, it's the number of cases against time. Anytime you have a 100% increase sustained over 2 time periods, it's the definition of an epidemic, or outbreak, or cluster. They all mean the same thing. A cluster, an outbreak, an epidemic, all the same things. I use the words differently depending on the impact I'm trying to make. If I'm trying to make an impact about a pretty nasty disease, I'll call it an epidemic. Or if I'm trying to keep the public calm about something, I'll say a cluster or an outbreak. But essentially they mean the same thing. The big twist for us is when this epidemic or outbreak is occurring globally, it's a pandemic. So never did I think in my lifetime as an infectious disease doc and a public health doc that we would see the 2 pandemics we have seen right on top of each other. I'm a little worried, why is our healthcare system so fragile that we are getting pandemic after pandemic? And I don't see this is going to end. I think we are going to have to be used to dealing with pandemics. So this epidemic or pandemic has the characteristic rise and fall in cases, and unfortunately for COVID, what's that?
You need to come closer to the mic.
Okay, that must be Jimmy. Jimmy's supposed to be at home. Tell Jimmy.
You can't hear it now?
Yeah, something wrong with the mic then. So anyways, this characteristic rise and fall of an outbreak or an epidemic is unusual in COVID because it depends on the variant that is present. The variant that we are dealing with now is nothing, not even remotely similar to the initial COVID-19 pandemic that we started with. So we'll talk a bit about that, but the good news is as we start getting experience in the community, more people boosted, more people infected, we start seeing a decrease in cases. So this is where we're at with the current COVID outbreak into these two BA4, BA5 variants now coming down the backside of them. Will there be another variant? Absolutely. Think about what the goal of a virus is. The goal of a virus is not to kill the host. The goal of a virus is to make more copies of itself. Viruses, though, can't make copies. They are not living things. They're not like bacteria. They can't replicate. What they do is they insert into the cell of a human or a mammalian, and then our cellular machinery makes copies. Okay? So what's driving COVID and these variants are not more virulent COVID variants, it's more infectious. So we are seeing highly infectious variants that aren't putting people in the hospital and aren't killing people. That's what's happening with the COVID. Nationally, that's the trend. If you go to the next slide. Can you go to the next slide? The trend is very similar here in Washington State. Again, a accelerated bump and coming down the backside of this pandemic. Now, Washington State, let's be really clear in Washington State. I found the first case of COVID in the United States, period. We have had more experience with COVID than any other place in the country. What I'm concerned about and is the fatigue that the public has about things that we know control the pandemic. That's wearing a mask, and that's limiting social movement or distancing. The public does not have much appetite for this right now. Quite honestly, people are really fed up with it. So it puts us in a very difficult place. We are one of the best states in the country as far as death rates. Our mortality rate was lower than anyone, but we were also very, very aggressive in limiting schools and restaurants and public gatherings and mask mandates. That comes with a cost. Yeah, it saved lives, but it comes with political costs and public cost. So it's not going to be an easy thing to get through the rest of these, but at least we're coming down the backside of one of the most infectious strains of COVID we've had to date. Just as a reminder, you're hearing a lot about the bivalent vaccine. Bivalent meaning it's got two different strains in it. Sounds a lot like the flu vaccine now, right? Yeah, that's where we're going. But it has these more infectious strains, the BA4, BA5, plus the original Omicron strains. So this is a very promising booster shot that should be in our arms within a week. Okay, next slide. It depends on where you're at in the state. Western Washington tends to be the leading edge of the outbreak. That's where the first case was found. It was found in Snohomish County, January 19th. My life has not been the same since, for better and worse. And in Western Washington, you see the epi curve has peaked and we're coming down the backside already. Eastern Washington is coming down the backside, but it tends to be a little bit slower. Tends to have a little more outbreak, higher, and a little bit later. So next slide. These are really by age groups. What I really want you to focus on is really just this pink in Eastern Washington. That's 80 plus. That is who is still at very high risk for bad outcomes. Most of the younger age groups, so you see the purple and the yellow age group, that's kids under 17, they're not really suffering high mortality and morbidity. It's the 80 and 80-year-old plus. There's at least, and everyone's, I'm so tired of conspiracy theory. I count the deaths every day.
I know what the deaths are from the death certificates. There's 20 people every day at minimum who are dying of COVID. Now, they're older and they're under underlying conditions, but they are still COVID positive, dying of damage to their lungs, not because they were killed in a car accident. And no, the state doesn't get paid for every positive person that dies. And no, I don't have 32, I don't know where this number comes from, 32 people in my basement that were refusing the vaccine. I don't even have a basement, by the way. These numbers are real. So when you hear all kinds of opinions and kind of these theories about stuff, don't give any of that any life. That is just so goofy. I don't know how our society has gotten to this point where we're not trusting data. Okay? And this is probably a good time for me to say, in public health, there's opinion. I don't really care what your opinion is. I don't really care about anyone's opinion right now. There's studies. I like studies, but sometimes studies are manufactured to support your opinion. What I trust more than anything is what we actually observe, what we count, what we see in Washington State. This is actual observation, not theory, not opinion, not a study. Okay, so next slide. Case ascertainment. This is what percent of, I just showed you these epi curves, what percent of those are the real cases out there? Because a lot of people are testing at home, right? So they get a positive at home, they're not going to call the public health system, they don't tell. Our case ascertainment rate, so what percent of the cases we actually know about, is around 12 to 13%. It's pretty low. That's very low. Okay, so the COVID issue is much bigger than the data you are seeing here. Okay? It's still very prevalent. It's not killing people as much, and it is not hospitalizing people as much, but it is still very, very infectious, which is the goal of a virus. Make more copies. Okay, next slide. One of the neat things that's come from our work on COVID, there's been a lot of attention paid to COVID, which I'll just take a minute to say, why did we not pay this much attention to public health before? Okay? If we would have had a robust public health system that was appreciated and funded, we would have seen this coming. We would have controlled it much better. Wastewater surveillance is one of these new technologies. This is where at wastewater facilities we can take samples and look for things like polio. You guys hear there's a polio case in New York City. New York City looks in the wastewater and says, holy cow, we got a lot of people shedding polio in New York. Okay, and it's the vaccine strain. But remember, none of us give oral polio vaccine in the United States. We're all injected polio. So where the heck is oral polio coming from in the United States? People outside the country, to be honest. So wastewater surveillance is a good way to detect where certain infections are, and we are doing it for COVID. These are the sampling sites within Washington State that are looking at COVID. You can see Benton and Franklin County are involved. So that is one of our lead indicators, and I want to see, are you guys in this area having a problem with COVID? I look at your wastewater, and your wastewater tells me, as good as that epi curve, sometimes better, that you guys have a significant problem. Understanding that case ascertainment is only about 12 to 13%. Okay, next slide. So here's the wastewater surveillance in eastern Washington. You can see it has very much the shape of an epi curve, but it's still very much sustained in eastern Washington. You guys are still having a lot of people shed COVID in your wastewater, which means they have it. Okay, COVID can be detected in your stool. Most of it, though, is in your respiratory symptoms. Okay, next slide. So here's our summary. Eastern Washington, you're seeing a plateau, maybe a downward trend. Watch your 0 to 4 and 80-year-olds. Western Washington just improving. And then case ascertainment is stable, and wastewater is probably our best indicator of overall infections right now. Okay, who pays for that, by the way? You do. That's right. Okay, next slide. Hospitalizations are coming down, obviously not as big as the peak before us, which was different strain, higher mortality and morbidity. This strain has a lower hospitalization rate, and it is again starting to decrease. Next slide. Try and get into a hospital in Puget Sound, though. Really hard to get into because now they're trying to catch up on all the work that hasn't been done. All the transfers from Eastern Washington to Harborview or UW systems, it's overtaxing the system. Okay. I'm just going to show you people who, this last column, by the county, people who completed the primary series, 79%. Assogan County, 46%. That's pretty abysmal. Columbia County, 48%. You can look at your own county here. I assume many of you are from Benton and Franklin. It's in the 60s. That's pretty good. Honestly, it's not near what it's going to take to have, and I hate this term, herd immunity. That's not near what it's going to take to have herd immunity. You're going to have to get a very infectious agent like BA4, BA5 that infects a majority of people, including those that don't vaccinate. Next slide. So here is a busy slide. I want you just to focus on this bottom one here, which shows you the percentage of variants. We, since COVID, have really sophisticated our whole genome sequencing at the State Public Health Lab and genotype outbreaks now. Think about this. If someone comes into your office for a stools study, you do a rapid diagnostic test, right? And it tells you it's salmonella or Shigella. How do you ever find out that's related to the 20 other ones that are positive in our office? We don't know. It used to be we would culture these and then genotype them and then freeze them and store them. Those days are gone. I recommend our public health lab now to stop doing cultures, just get some DNA or RNA, and let's genotype it and keep that whole DNA sequence for every outbreak of public health significance. Then you don't have to store it in the freezer, and then you need information technology. This is what they produce. Out of all our COVID-based sampling, this percentage, which is 84%, is BA5. Okay? 12% is BA4, and BA2 comes into 2. Does that really mean anything? Yeah, it does, because we have clinical correlates to those variants about how deadly they are, how infectious they are. So what we're dealing with, and I keep saying this, is a very infectious variants, BA4, BA5, that evade prior vaccination or prior infection. So this is why the bivalent vaccine coming out covers BA4 and BA5. Okay. Next slide. It's really confusing what these vaccine products are, but essentially they are all EUA, emergency use authorization. That does not mean they aren't studied. These vaccines are studied more than any of our other vaccines that we have. They were done in series rather than year-long ways, but they are very highly studied, very safe. And you can read here for yourself who they're indicated for. 6 to 11 months is the newest one, but now the bivalent coming out probably next week. Okay, next slide. Monkeypox. The thing about monkeypox is it is a cousin of smallpox. It's an orthopox. So chickenpox is not in that same orthopox. It's a monkeypox, variola, or smallpox. Cowpox, camelpox, horsepox, rabbitpox, raccoon, skunk, and bull. There are two strains of monkeypox. One is very deadly. The other one is mostly more infectious, and that's the West African strain. Lower fatality, less transmissible person to person. None of our cases of monkeypox in Washington State have died. Okay? They've had rash, blister, fever, pain, but they have not died. Okay, next slide. This was really identified way back in the 50s. The first cases we had were in the 70s. We had endemic cases or outbreaks in Central and Western Africa, but they tend to go away. In the United States, we had one outbreak in 2003 of 81 cases. Was associated with rats, I believe. But so we've seen it before. So why now? Why is it 500 cases in Washington State? What the heck happened? Next slide. The only way you really can get this is you got to have contact with the lesions, or the fluid, or the scabs, or the sexual fluids that are contaminated with the lesions. And it's really through your skin. You're not going to catch it riding on the bus. You're not going to catch it in Walmart. You're not going to catch it breathing the air of someone unless they're really in your face with lesions. And it's prolonged. None of our cases in Washington fit this category. All the cases in Washington fit direct contact with someone with monkeypox. It can occur in healthcare settings through bedding. That hasn't really been an issue here in Washington State. Out of 500, it's mostly men who have sex with men, who have genital, anal, or oral lesions. It isn't just limited to this. I mean, let me tell you how this story goes. A woman comes into your office and says, hey, I have a lesion. Here, I'll give you a lesion. That's actually a blister from shoveling, just so you know. That's how wimpy I've gotten during COVID. I shovel and now I get blisters. She comes in and she says, hey, provider, I have a lesion. It doesn't make sense.
Well, you're not going to get monkeypox because you're not a man having sex with men. All 10 of the women who have come in multiple times trying to convince us as providers, please just test me. So what I'm telling you is open your mind. Any unexplained lesion, ask the question, have you been around someone with monkeypox? Oh yeah, my sister has it. That would have been an easy yes, we'll test you. And now you can get testing commercially, not just in the public health lab. Transmission in the healthcare settings is a worry. We do have one healthcare provider who has it in Washington State, and I'm putting all stops on them saying, you aren't working. And they're like, well, but then you're going to out me. People are going to know I'm a man who has sex with men. And I'm like, you know what? You take care of immunocompromised people. I don't care. This is more important. So anyways, next slide. Usually incubates about 1 to 2 weeks. Really gives you fever, headache, muscle aches. I mean, come on, everyone's going to think you got COVID. That's all anyone thinks about right now is COVID. But once you get this rash, it's this flat red macule that turns into a papule that turns into a vesicle that then pustulates and scabs. It is not, honestly, this blister from shoveling, that's what it looks like. It's a lot smaller, but that's what it looks like when it gets to the scabbing stage. And then you're less infectious. But any unusual lesion, especially on your genitals, in your anus, or in your mouth, is very worrisome and ask further questions. Usually lasts about 2 to 4 weeks. And the fatality with our strain that we're seeing here, and we're genotyping them now too, it's a very unusual strain out of West Africa, does not have a lot of case fatality. I think we have only had about a dozen people hospitalized, and most of the hospitalization was for pain management, because these things really, really hurt. Okay, next slide. Here's what they look like. Kind of looks like a pimple, kind of looks like a chicken pox, kind of looks like, oh, that might be smallpox. It can be pustules, just like these pictures are. They're often painful, and they may start in your mouth, so don't forget to look in the mouth of someone who has rash on them. Okay, next slide. How do you identify it? If you're thinking chickenpox, molluscum, syphilis, herpes, chancroid, cocci, which is hand, foot, mouth, mono, or any other vaccine-related rash, you better just swab this thing and get a monkeypox test done on it, so we know. It's amazing how many people didn't think it was monkeypox, they swabbed it. It's positive for monkeypox, and then you go back and you find the epidemiology was, oh yeah, my cousin has it. So anyways, this is heads up for you all. Next slide. There are a couple of things you can do once you have it. The best way is to vaccinate to prevent it. How many of you, well, you don't, I don't have to call you out, but I have a smallpox vaccine in the last 9 years, back when public health, do you guys remember this? Yeah. Oh my God. Oh, you do? Yeah. We are protected to some extent against monkeypox. Okay, the smallpox vaccine has protection against monkeypox, but the new monkeypox specific vaccine, the Jynneos vaccine that you're hearing about, is a much better vaccine choice. That is what we have to treat anyone who has been exposed to an actual case, as long as it's within that incubation period, 1 to 2 weeks. That works pretty good. That is what is slowing down our outbreak right now, and I'll show you these numbers in a minute. It can be also used for someone who is at high risk, who hasn't been exposed. So suppose you're someone who engages in male sex with other men. You go, and I learn a lot about social norms in groups as we have outbreaks. If you're at high risk for this, the obvious thing is don't touch someone's blisters on their privates, right? But being vaccinated before you even get into this situation where you may not recognize you touched someone's lesions, it can protect you also. But there isn't enough vaccine to say, hey, this is called ring vaccination. There's a case, we vaccinate everyone in a ring around them. That's how we got rid of smallpox. There's not enough vaccine to do that. So it's great to give it to people before they're even exposed, it's just not enough yet, okay? And you as healthcare workers, unless you are directly touching lesions without gloves on, then you're not at risk. And so you are not a candidate for the vaccine because you can wear gloves, you can wear a mask. Okay, next slide. Was first reported in the UK, and then it started spreading everywhere. Next slide. These are what the cases look like around the world when it first started. These are multiple countries, so this is by definition a pandemic. Next slide. The way to identify exposures is, have you been around a case, to be honest. This is the best way, and you gotta ask these very sensitive questions. Like, have you been around someone with monkeypox? That's not too bad. Have you been around someone who has sex with men? Or do you have sex with men who have sex with men? These are really uncomfortable questions to ask in the office, but that is really what's going to get you to identifying your exposure. Next slide. You isolate, very much like COVID, until your test result is done. You cover your lesions. Mask if you're going to be face-to-face, and don't share things where the lesions can get on it and share. And do not travel. I can't tell you, it's a full-time job for me to stop people at SeaTac and say, hey, you were diagnosed with monkeypox. You should be at home. You are not getting on this plane. Okay, next slide. We do contact tracing. We monitor anyone who's been around a case for 21 days. And for healthcare workers, if you've been around a case, you really should be monitoring for fever or any symptoms. Okay, next slide. It's going to be a hard one going into the flu season. Washington is the 11th most common state. We are now up to 500 since this slide was created. But New York is way higher than this now. Okay, next slide. This is what our epi curve looked like in the early beginnings. Where we're at in the epi curve right now is we're starting down the backside. Since August, we're having a decrease in the cases. So I think this outbreak, epidemic, cluster, whatever you want to call it, pandemic, is starting to abate here in Washington State because of very aggressive use of vaccine. Okay, next slide. And this is the epi curve spelled out. We are now, and this is really up to us. We're about right here now. So it's a pretty significant.
Sorry, we gotta try to keep kind of near the mic if possible.
Yep.
Yeah.
Next slide. Peaked in New York. We're behind New York. This is what we're looking like. Next slide. TPOXX, this is an oral or an IV formulation. You can use it. Any of you guys can prescribe it. It's very cumbersome to get approval on, but it is out there as an oral for anyone who is actually symptomatic. It's been safe. Next slide. Here's the vaccine I talked about, the Jynneos. Next slide. How do you do this? What they found with Jynneos is instead of giving a single intramuscular or sub-Q, you can now do it intradermal and use 1/5 of the dose. So all of a sudden, the very shortage of the vaccine can be spread. In theory, we're finding it doesn't really translate to 5 doses out of a vaccine. It's about 3 to 4. But just like a TB skin test, you can put this vaccine on people in your office, right in the arm. Next slide. Just like a TB. Next slide. This is where it goes. Next slide. Looks just like a TB placement, TST. There you go. That's monkeypox. I think we aren't going to talk about this next year because I think it's going to be gone. Okay? What is going on behind the scenes here is large number of avian influenza in our waterfowl, wild waterfowl, but this takes a hop, skip, and a jump to get to a backyard flock. That one's not so worrisome, but it is if you're a commercial producer of chickens or turkeys. This will decimate your business. Multi-million dollar damage. And your counties have experienced this in the past. So here it comes. Again, it's full force across the United States right now. It's H5N1. Next slide. And it can transmit to human. We have yet to have any of our high pathogenic avian influenza outbreaks in Washington translate to a human yet. There have been no human cases. So this is mostly a zoonotic infection at this point. Next slide. So here's our current situation, the number of wild birds, the number of poultry, and the number of humans, 1 human case. Next slide. In Washington, the total number of backyard flocks at the time of this slide being made was 32. And all those people around those 32 flocks, not 32 birds, are monitored for high pathogenic avian influenza. And when they get flu-like symptoms, they get a COVID test and a flu test to see if they have it. We've had no H5N1 avian influenza yet, but it's going on as we're talking. TB outbreak in jail. Next slide. It's the risk for TB transmission is much higher in prisons for the obvious reason of risk factors are higher. If you really look at who gets TB in the United States, it's foreign-born folks, okay? And beyond that, it's people who are homeless or in prison or are injection drug users. Usually what we see is about 27, or in incarcerated individuals, we see maybe 1 or 2 a year. What we saw in July to September of 2021 was 27 new TB infections, and 2 of those were disease. Next slide. No source case. Of course, the prisoners are all convinced it's the staff giving them TB as punishment. And then in December through January, 3 new TB cases in a different facility. Next slide. And so the goal here is find these TB disease, treat them, test them, and try and figure out where this is transmitting from. People in prison, and I hope you guys all know you have the mother of all prisons in Washington State in your backyard, Coyote Ridge. I don't know if you know that. You know that. You and I have been there testing. It is huge. This is where TB is transmitting. Why I'm talking to you guys today is I really want you to up your ante for looking for TB. For example, you have a 37-year-old Hispanic woman who comes in your office who's lost 20 pounds and has been coughing for 4 weeks. You better think TB before you even go in that room and put your N95 on. You probably have your N95 on because you're thinking about COVID, but you're going to miss the TB diagnosis. And asking questions like, has anyone in your family been incarcerated? Has anyone in your family had tuberculosis? That's why I'm talking about TB in incarcerated individuals. So these residents move from prison to prison all the time. So they are moved across the state. So Coyote Ridge is one of the larger facilities that tends to rotate a lot of people through it. Okay, next slide. 20 outbreak cases as of May 15 cases. Okay, next slide. When we do whole genome sequencing, this is again same thing we're doing for COVID or monkeypox, we're finding that they're all related to each other. Out of 2,600, now it's about 2,800 resident contacts, about 1,600 of them had no history of ever being tested for TB, and the staff, 118 without TB history, were positive. So it is spreading within our prison system right now, and we have not found the source of it yet. Next slide. So newly positive, come to the TB talk later. I'll talk to you about what positive means versus having TB disease. We don't have time to go into it right now, but about 1/3 of the world is infected with TB. 13% of all these people we tested are infected with TB. Doesn't mean they have disease, but Same with the staff. Next slide. Homelessness and public health. Next slide. In Washington State, about 21,000 people are homeless at any given time. You can see the counties that it affects mostly. King County, the Puget Sound area tends, have you been to Seattle lately? It ain't pretty. But these are the county, half of the state's homeless are in King County. Next slide. Here is the contributors to why there's an increased burden in diseases in folks that are homeless. It's obvious things like unsanitary conditions, crowding, poor safety, underlying medical conditions. This is like if you've ever worked in a refugee camp, this is exact same feel, same risk factors. Here in the United States, that's embarrassing that in a country as rich and developed as our country is, that we have situations like this. 21,000 people. Next slide. So here are the most common problems, high blood pressure being the highest. Chronic musculoskeletal, dental, intestinal, you can read the list for yourself. This takes a lot of work to deal with homeless populations. Next slide. Communicable disease, always been well known. There's a book written on this, Healthcare of the Homeless Persons, common problems in shelters and on the streets. So disease significance here in Washington State within our homeless population is tuberculosis. It's not just in the prison system. Hepatitis A outbreak, meningococcus, scabies, and group A strep. And I'm not talking about strep throat, I'm talking about strep in your soft tissue. Next slide. Behavioral health and public health, we don't usually talk about behavioral health in the public health world, but COVID has changed all of this. Any drug overdose death from 2017, 1,163, to what is currently double that number, 2264. Our overdose death rate in Washington State is higher than it has ever been. And you can go through your specifics, diseases. Psychostimulants is really the newest, latest, and greatest. And we're talking about things like manufactured fentanyl. Have you seen these things? They look like candy. They look like Skittles. Yeah. Next slide. Proportion of drug types in these overdose deaths, you can see them here. It's really the biggest issue is it's opiates and psychostimulants. Next slide. And overdose deaths by months and 3-month average amongst our Washington residents. It looks like it's starting to come down right now because there's getting a bit of attention to this in the Puget Sound area. I think what you have to ask yourself is what you're doing in your county region right now for overdose deaths. Prevention. Next slide. Overall drug overdose deaths by county, compare 20 and 21. 2021 is pink. Yeah, I'm sorry, it doesn't really show up good against a red, but you can look at yours, for example, Benton and Franklin, not the biggest drivers of the state, but you still have some significant drug overdose here. Okay, next slide. What's nice is we've watched through COVID psychological distress in the ED visits, and these are watching the percentage of emergency visits for psychological distress have remained very high during COVID. Looks like we're starting to come down a little bit. Okay, next slide. Suicidal ideations, pretty much the same, remain high, but starting to show some improvement in the last couple months, last quarter actually. Next slide. And those that are ED visits for behavioral health also reported as homeless, very high rates in our homeless also. Next slide. Okay, there. I know I keep getting time punched, thank you. But let's have a little time for questions if you want to ask any questions about anything specific. That's a lot. Sorry, it's like shoveling a ton of data at you. Yeah. You're first.
In regards to the immobilized rash,
Mhm.
it seems to evolve over the course of a couple weeks or so. But it sounds like there's a few stages in between that. Is there like a specific time frame usually how it evolves?
Yeah, it usually starts as a red papule. It depends on how good your immune system is. If your immune system is good and you've had a smallpox vaccine before, it's gonna be unusual. It may just be a red bump. But asking that question, have you been around someone with monkeypox, would do it. It's hard to get a test on something that is a dry lesion. Remember, Viruses aren't on top of cells, they're in cells. To get a sample of a virus, you actually have to pick up cells. So unless there's an actual blister, probably not gonna be able to recover it. But yeah, it can be atypical depending on the immune system. If you are full-blown low CD4 count, it's gonna be even more accentuated, like head to toe. Yeah. So, yeah. Yeah.
Following along the same lines on that, what amount of vaccination, actually you have if you have the small vaccine?
About 70%. Yeah, it's pretty good. Yeah, but here's the lesson. Don't touch anybody's blisters, especially if it's on their genitals or in their anus. There, that's even more effective. Okay, you're next. Yeah, sir, in the front.
Oh, wait, sorry.
I'll repeat your question.
Do you know how long the virus, the monkeypox virus, survives on a surface? Off of
Yeah, the question is, how long is a monkeypox virus viable, because they're not alive, viable on a surface? And it's probably about 12 hours. Depends on, too, if it's in direct sunlight, if there's bleach on it, if there's, a very dry environment, then it desiccates. This is why we use, I love this, you look at antiviral cleaners, it says kills 99.9% of all viruses. Right then, I'm like, no, they don't. Viruses are dead. What desiccates a virus is UV light, bleach when it dries, not when it's wet. So if you, I love this, you guys all like the hand gels, you put alcohol hand gel on, and then you wipe it off, didn't do any good. You just wipe viable virus all over you. So really, UV light and alcohol that evaporates, or bleach that evaporates, desiccates the virus, the shell of the virus, so it can't infect. So, yeah.
So with the Jynneos vaccine, any timing of other vaccines, such as bivalent, is there time, can we give it all at the same time, or where?
Yeah, I don't think we have the luxury. If you've been exposed, that takes precedence over everything else. I don't care what you had the day before, just get the vaccine.
How about after that? The Jynneos?
Yeah, ideally, you wait. There's not any real evidence that it interferes with other live virus vaccines. But again, everyone's immune system's different. If you have AIDS, not HIV, but AIDS and very low CD4 count, you're gonna talk to your specialist, the HIV specialist, before you give any other vaccines. But if they were exposed to monkeypox, get on it right away. Yep. Or put them on TPOXX, the antiviral medicine. Yeah. Yeah.
I have two questions. One is regarding the COVID. The other one is about monkeypox. So now we have a lot of people do home test for COVID.
Yep.
And then that's why we don't really have an accurate data of how many positive cases. And public health data is very important for like a travel guide.
Mm-hmm.
And do you have any anticipation for, like we will do normal travel, when we cross the Canadian border, no one asks for vaccine status, something like that? That's first question. And second question is about monkeypox. And you mentioned about all the 500 positive patients in Washington State, you have a way to do the case tracing. And they can be stopped at the airport and saying, okay, no travel. So how did you do that? I'm just curious.
Okay.
Thank you.
So the first question about what is a good surveillance system for any disease? Let's take flu, for example. We do not know every case of flu that occurs in the community. We follow the trends with a case ascertainment rate of about 1%. So I'm comfortable with people testing at home as long as they're using that information to stop exposing other people. I think that happens for the most part. I am comfortable doing a surveillance system on COVID that moved from what we always thought we were counting every case, we never were counting every case, to a case ascertainment rate of 13%. I am okay with that. what we are seeing, and everyone keeps talking about, we're in the endemic phase of COVID. No, we're not. Endemicity means there aren't peaks and troughs. And our peaks and troughs occur every 3 months. So in a year from now, if we've only had a little bump, then I can say we're endemic. But I can't say that right now. We do have a little bump right now. It looks like it is the beginning of endemicity, which means we got to learn to live with this virus, just like we do with flu. But unlike flu, you guys are all much better mask wearers now. So I am trying to normalize the use of masks when disease rates are high enough. So no, the governor just announced on October 30 or 27th that all rules in the state are gone for COVID. Still remains a mask requirement from the Secretary of Health, from Department of Health, for healthcare workers must wear a mask in the healthcare setting. So it's gonna get back to normal. It's really painful. I think I see it as like water skiing. It's really hard to get up on the water, and then once you're up, you're kind of like, oh yeah, this is easy. And then you're like, oh, now I gotta get down. That's hard too. We're getting down off a pandemic, and it's really painful for people. There's some people who think we're not doing it fast enough, and there's other people that are very anxious that we're doing it too fast, which means we're probably doing it right if we got both sides upset. Okay, that's question number one. Question number two, monkeypox. What were you asking about monkeypox? Say it again.
How do you trace the cases?
Oh. Yeah, so when we hear about a case and it's positive, we then call the individual. The public health officer in your county has the authority, that's Larry right now, to mandate someone to give information. And he can actually put them in jail if they don't disclose who they've been around. It's called ring vaccination. And there's also the authority to take that person's name if we think they're flying, and then I talk to the Division of Global Migration and Quarantine, which is CDC, and I say, Larry Yecca is trying to get on a plane, please hold any flights for Larry Yecca for the next 14 days, and they do, and so they stop you at the gate. Yeah, we have that authority. It's all written in state law that the health officer has, not you, not me, but the health officer. Anyone name that song? So yeah, it's powers of the local health officer. Okay, any other questions? Yes?
I'm curious about the wastewater screen.
Yeah,
That's kind of new to me for some reason. And where do you, so what's the scope of diseases that are screened, and how do you access that information?
So public health has the authority to do, thanks. Public health has the authority to take samples from the environment. So the only things we screen for now are COVID, because it's new technology. We are gonna add polio to it, and we could add any other disease of importance to it, like monkeypox. People are talking about, let's do monkeypox too. Well, who does it, who pays for it? And you gotta be honest, we're all overworked right now. Our lab folks have enough to do. So unless the juice is really worth the squeeze, I'm not an advocate for it. I'm still learning on COVID what it really means, and what I'm starting to see, especially thanks to your area, it precedes your case counts. So it seems to be a good predictor of, is there a lot of COVID in your community? Yeah.
Go to bfhd.wa.gov, and those charts are on the wastewater chart.
Mm-hmm.
So when did New York City start looking for polio? Was that recent?
About 4 weeks ago. Brand new.
Do you think it was there before?
Yeah, I think it was there because they had a case there, and the person who got it never traveled outside of the United States. So yeah, so this is what I mean. This is the kind of stuff we should have invested in public health infrastructure before we have these outbreaks. The first case of COVID was detected by my team. It definitely wasn't the first case of COVID in the United States. We were just on it. That's all. If we would have been looking for COVID a month earlier, we probably would have been ahead of this game. So, I mean, I sound like a broken record trying to advocate for a stronger infrastructure for public health. But think of public health as a house that's crumbling. The foundation is crumbling. And we get money to fix the third story apartment, COVID or smallpox. if you're not investing here, you're gonna have a nice third floor story apartment that's gonna fall down. And that's kind of what's happening. Yeah. So wastewater is another one of those shiny new tools we should have been using months ago. Yeah. Yeah.
Can you quantitate the like the number of people in a community that might have shed that virus or that organism into
Yeah,
the
that's a
wastewater?
great question. That's my question that I'm asking the wastewater folks is, yeah, so what does this mean? Can you really quantify it? And I see these big bumps, and you know what they correlate with? Rainwater flow. So as the flow increases, because stormwater is in wastewater, I don't think we've modeled it well enough. We haven't had enough experience to be able to model how does this really predict how many people in the community have disease X. But yeah, this is definitely the question we're trying to get to. It's kind of nice too. You don't have to ask permission for swab someone's nose. You just get their poop. Yeah. Okay. How are we on time? We okay?
2 minutes.
2 minutes. All right. Any burning public health question you want to know? Okay.
So I oversee the inmate care in Yakima County, and it's always an issue regarding when do you screen, when do you not screen? Because the length of stay can vary from less than 24 hours to 6 months, and you don't know that until they're in for a while. And we used to screen everybody all the time for, with PPDs, and of course COVID was screened and all that. Now we're not really screening anything. We've certainly had skin lesions, for example, coming in, and the nurses are like, is this monkeypox? And we're not screening. So I guess I'm looking for, are there some prudent guidelines for when we have these outbreaks, how you approach your inmate population?
Yeah. So a couple things. The most promising model for this is being presented by Mark Stern and Lara Strick. Lara used to work for Department of Corrections, and as of last Friday is not working for Department of Corrections anymore. They are proposing an intergovernmental agency that does public health recommendations for incarcerated individuals. So it works with Department of Corrections, with Department of Health, Labor and Industries, Health Care Authority, all these agencies to really have good recommendations for exactly what you're saying. When do you screen for stuff? Here's my quick, cheeky answer. You screen for things when you're gonna do something with that answer. Okay, and if there's anyone in here who's a resident, this is the same thing for labs. Do not order a lab unless you are gonna use that result. And you know what you're gonna do if it's positive or it's negative. Don't order the test and go, oh my God, what do I do with the result? So I'll say it very simply. Labs and screening are like boogers. Don't pick them unless you know what you're gonna do with it. And as goofy as that sounds, this is what Department of Corrections and jails need to do is we're not just gonna screen people because I don't know what I'm gonna do with that result if it's positive or negative. We don't have enough space to isolate people. Well, then don't screen. Treat everyone as if they have. We learned this lesson. I don't know if you've been here long enough, but when HIV first started, jails and prisons wanted every inmate tested for HIV. And when it was positive, they were extra careful with that person. And when it was negative or unknown, they were less careful. And that's where the transmission occurred. Because the goal should have been we treat everyone, and we do now. We treat everyone as if they have HIV. Maybe we get to the point during respiratory virus season as COVID becomes more endemic that, hey, every winter, everyone gets respiratory isolation. The staff wear masks because guess who brings in a lot of COVID into jails and prisons? It was the staff. It wasn't all inmates, it was a big portion of the staff. So screening has to be incorporated with what are you gonna do with the results, both positive and negative. So, does that help?
Oh yeah, we did that forever and we didn't do anything with the data, so we stopped.
Yeah, that's right.
And now here we are like, oh dear.
Now, what are you gonna do? Okay, all right, well, thank you very much.